cubic mm. Differential count falling off 73, lymphocytes 18, eosinophils 4, monocytes 5, ESR 110 millimeter at the end of first hour. Platelet count 71,000 per cubic mm. Blood urea 101 mg per dl. Creatinine 8.6 milligram per dl. Serology was non-reactive. Sodium 128 mg per dl. Potassium 5.6 milligram per liter. Calcium 7.7 milligram per dl. Uric acid 6.9 mg per dl. RBS 110 mg per dl. Thyroid profile was normal. Bleeding time 2 minutes 30 seconds. Clotting time 5 minutes 10 seconds. Free time with INR was normal. LFT was normal and lipid profile was normal. Routine urine and microscopic examination of urine level. Sugar nil, albumin 2+, plenty of RBC seen, RBC class present. 24-hour urine protein showed 0.6 gram per 24 hours. This is the chest X-ray PA view of the patient, which reveals normal bony thorax, trachea as a midline, and a homogeneous patch of opacity seen in the left lower lung peak. And hypertension can be seen. USG whole abdomen revealed right kidney size 10.13 into 4.04 cm, left kidney 10.46 into 4.20 cm. Normal size in echo, but bilateral corticomedullary differentiation was reduced. Feed fluid noted in pouch of Douglas. ANA was negative, anti-DSDNA negative, C-ANCA, P-ANCA negative. Serum complement level was 0.9 gram per dl. Normal range was 0.9 to 1.8. ECG normal. Echo revealed mild tricuspid regurgitation. Pulmonary artery pressure 30 mm of mercury. LVEF was 69%. Blood group of the patient O positive. So next we considered kidney biopsy of the patient, which revealed multiple serial sections showed 12 glomeruli. Glomeruli, all of them showed fibrous crescents. Basement membrane of these glomeruli were single contoured and ruptured at few places. Tubules, evidence of moderate degree of acute tubular injury was seen. Interstitium scattered lymphocytes. No features of vasculitis seen in vessels. On immunofluorescence, 6 viable glomeruli seen. All showed crescents. It was strong linearly positive along capillary walls with IgG 3+. This was the light microscopy of the biopsy taken from the kidney. And these are the crescents. This is H&E stain and this is methenamine silver stain. This is the immunofluorescence staining, linear staining of IgG deposits along the kidney membrane. Kidney biopsy finally confirms descending glomerulonephritis, sclerotic phase, secondary to anti-GBM nephritis. So we did anti-GBM IgG titer, which was more than 300 units per ml. It is said to be positive and it is more than 18 units per ml. So our final diagnosis was anti-GBM.
So this is the one of the four varieties of vasculitis you have seen, shown you. Two of the anti-associated, one immunocompressed deposits, four varieties you have seen the vasculitis. This time this is the peculiar with the central hospital. We usually present all the neurology. This time we have presented four types of vascular different varieties.
Is there any hemoptysis in this patient?
No, not at all.
So that is the views I was just telling. The anuria, first presentation in a patient with the SLE, they are extremely uncommon. Extremely uncommon. So I have probably not seen a case of SLE presenting with only complete anuria. And second is in your differential diagnosis, you are told about the nephrotic syndrome. Nephrotic syndrome having hypertension, nephrotic syndrome having so much edema, is it that common? And with only 0.6 gram of your proteinuria, do you think that you still believe that it was a nephrotic syndrome? You, in your initial diagnosis, differential, you showed that probably. Yes.
But generally,
so this is one thing. This is a rapid pulmonary glomerulonephritis. There should be along should be the pulmonary involvement. But there is one kind of cases you can get this the GP syndrome where you will get only there is RPGN. Otherwise, there should be a combination of the RPGN along with pulmonary involvement.
now one point I want to mention.
Sir,
In the latest traditions, if you go to, just reading yesterday about the IgG related tubulointerstitial disease, particularly systemic diseases. There are a lot of other organ involvement, but there will be renal involvement also. IgG4 related diseases. So there will be other involvement. I think there are a lot of other components, but still that may be initial position. An anti-GBM, but I also don't disagree with or agree with Dr. Shumendu Ghosh that ACD will not have complete anemia because that will depend upon the what is the structure involved. You've got a complete tubular cast. If you have got there will be tubulopathy also in ACD. So if that is tubular precipitate, there will be some complete anemia. It's not very unusual in this area.
Yes, sir, and particularly sir, good posture who reported in 1936. First case, it is a generally pulmonary and followed by renal, or sometimes renal only. 60% and 20%. This group is fast presentation in renal. Later on, the clinical spectrum may involve this. That's why, but it was been proven.
Sir,
Generally, fast renal followed by pulmonary followed by renal.
Sir, there are plenty of hospitals they cannot afford to do anti-GBM. Can you just think of this only rapidly proliferative glomerulonephritis,
Yes,
particularly post-streptococcal and others?
RPGM,
Whether the treatment policies
No,
of these two diseases will differ.
no, RPGM, there is definitely, it may be ANCA-associated, non-ANCA immune complex deposits will be there. So ANCA-associated will be there, will be polyangiitis, ignorance glomerulonephritis will be there. There is some drug induced also, there is penicillamine and will be there also.
And cause positive.
SLE will be there, HSP will be there, those there can be also positive wound processing.
No, ANCA was negative, not positive.
This is not usually there may be ANCA not associated. Good posture disease is the number one cause. Then the ANCA associated disease, which causes also pulmonary hemorrhage with the RPGM, and the other causes like SLE, HSP, this will be there. Here we have not started giving any type of the immunocompromised because already this glomerular completely sclerosed. If you treat the initial phase, if it is already sclerosed, automatically if you don't treat person, within 18 months to 20 months it will automatically recover. So if patient does not recover, patient is now in the renal replacement therapy in the form of the CAPT. Patient is with us now also.
Okay, now I invite Dr. Saurabh